It's my pleasure to introduce Dr. Anurag Saxena. He is cluster head of the neurosurgery department of Manipal Hospital in Delhi NCR, I suppose. And he, after doing MCH in neurosurgery, he did his FRCS in neurosurgery from UK. His areas of interest are cerebrovascular surgery, functional and complex spine surgery, modern preservation spine surgery, endoscopic brain surgery, endoscopic spine surgery, skull-based neurosurgery. So almost all the fields of neurosurgery he is skilled and is interested also. He has done his fellowship in spine surgery from Lancashire, UK, and again fellowship in pediatric neurosurgery from Royal Liverpool Elder Children's Hospital, Liverpool. So I think UFC qualifications are very impressive, and I request him to start his talk on comprehensive neurosurgical care based basically on case presentation. So Dr. Anurag, you can start your talk.
स्पीकर के ऊपर
Namaskar. First of all, a big thank you for that, sir, for a kind introduction. And I apologies for being late. Delhi traffic was not kind to me tonight. I'll quickly go ahead with the presentation, but just to give you a heads up, comprehensive neurosurgical care means not just surgeries, but also the advances which we are using, as well as the neurorehabilitation and a lot of other things which goes into producing the clinical result what the patient desires. So I will be presenting some cases. Basically, these are just photographs. These have been already consented for, and all the videos which you see have been consented for. मेरी आवाज आ रही है वहाँ तक आपको सब? Right. So again, no conflict of interest. I'm not promoting any implants, or I'm not promoting any navigation systems, any brands here, but I'm just going to show you the recent advances, how neurosurgical advances are helping us to achieve very good results in complicated cases and cases where we question ourselves. So no conflicts of interest here. Manipal Institute of Neurosciences, it is a big institute. It means we have neurosurgery, a very comprehensive neurosurgery department. Neurology, we have a very strong neurology department. We have been supported by 3 very senior neurologists. Neurointervention, which means all endovascular, all vascular interventions which can be done in catheter, we are doing that. We have a dedicated neuro ICU. We have dedicated neuroanesthetist. We have a team of 2 senior neuroanesthetists who are supported by 6 registrars. And we have a dedicated neurorehabilitation. Our head of department of neurorehabilitation, Dr. Dharam Pandey, specializes in stroke management and neurorehabilitation post-stroke and post-spine surgeries. So this is, as Dr. Poddar has already mentioned, we do all aspects of neurosurgeries, including from neuro-oncology till peripheral nerve surgery. I've kept pediatric neurosurgery in the center because it is one of our areas of specialty. There are very few centers in Delhi NCR, I would say in India, who have dedicated pediatric neurosurgeons, so pediatric neurosurgery setup, and we are one of those. We do a lot of spine surgeries. Almost half of our neurosurgical work is spine, and that is what we are going to discuss first. Minimally invasive spine surgery, आप सबको पता है, the name itself says that it is spine surgery by doing small cuts in the skin nowadays. We do not even dissect muscles and do not even cut bones nowadays. We just drill and make small holes. The obvious advantage is just like a laparoscopy surgery. It is less painful, it is minimal complications, faster recovery, early ambulation, patient can go back to normal work. And this is the crux exactly. So if you are giving a big cut in the back to put screws or spine in the spine or going to the spine, you have to cut the skin, you have to cut subcutaneous fat, then you have to cut the fascia, then muscles, and you cause a lot of injury because then you have to denude the bone and then you do the spine surgery. So this is the traditional spine surgery approach. However, we can do this without putting small tubes inside without disrupting normal anatomy. So if you are able to respect the normal anatomy, the patient can walk early, the patient can go home early. Coming to bread and butter, this is a pre-op MRI of a patient and this is a post-op MRI. If I would have shown you just the post-op MRI, you can see there is a big disc herniation at L4-5 level here. Right, this is a post-op MRI. There is hardly any imprint or signature of the surgeon. When I say signature of the surgeon, it means the scar, the amount of tissue I have removed, and the amount of disruption and the inflammation which I have caused. So, surgeon का signature जितना छोटा हो patient का उतना अच्छा होता है. So, minimally invasive spine surgery helps us to do that, and this is how we do it. So, we normally put small tubes through the skin, small cuts. Whenever you refer a patient for endoscopic spine surgery, sciatica, slip disc surgery, endoscopic surgery, or minimally invasive spine surgery, this is how we do it. The small tubes are placed on the skin. Through this skin we put a dilator, and through this dilator we can either remove the disc, we can remove a tumor, we can do fixation surgeries. So this is the procedure in a nutshell. This is the finger of a surgeon. The thumb, the diameter, length of this scar is not more than few centimeters, and patient is able to go home. Delhi patients we are discharging in next day after surgery. Patients who are outside of Delhi, we take them 48 hours in our hospital just for one more course of IV antibiotics and some physio, and then we discharge them within 2 days of a simple slip disc surgery. For a complex fixation, our average time hospital stay is 3 days only for a fixation surgery. And this is, we are doing endoscopic also, but I'm not going to go into the detail. It is further specialization of the endoscopy, the surgery which I have told you. But then there are certain cases where disc ही खराब है, and the disc is okay. आपने MRI, आपने बहुत सारे patients के MRIs देखे होंगे, where patient is complaining of back pain, continuously back pain है, there is a band-like pain in the back, and MRI shows that there is only L4-5 or L3-4 or L5-S1 disc desiccation. That's all it shows. It doesn't show any disc herniation, any disc nerve compression, but the patient is complaining of pain. आपने physio में भेज दिया, medicine दे दी, patient will come back to you again after 2 weeks, maybe after 1 month. The patient is pain में वापस आ गया, pain नहीं जा रहा कहीं पे, because the culprit is the disc here. So इस MRI को अगर आप देखेंगे तो at the L4-5 region, you see this disc is black. The rest of the discs are grey in color, which means they are well hydrated. But this is a desiccated disc, which means it is lost in water and it is bulging. Disc is a pain-sensitive structure. Disc का जो annulus होता है, it has a C-type fibers which are nociceptive fibers. So whenever the disc desiccates and the patient, the weight puts on the patient and the disc bulges, this pain fibers will stretch and they cause pain. And this is pain which typically patients complain of back pain, which is not going up to the hip maybe, but not going to the legs. And this pain is recurrent. बार ये pain आएगा. Eventually the disc will disappear and the bones will start rubbing each other and the pain becomes surgical, then you have to do fixation. So in those cases we are able to replace the disc. Not just discectomy itself, but replace the disc. The cervical spine disc replacements are much more common. It is just like a hip replacement or a knee replacement which you are doing for the patient. So that's artificial disc will give you same degree of flexion, extension, axial rotation, which are not, where the hip joint implant will give you or a knee joint implant will give you. It is very good for young patients, patients who do not have any facet problem, patients who have multiple levels. Because if you are putting cage at multiple levels, you fuse the spine and you reduce the mobility of the spine. So artificial disc, we are regularly doing it for cervical spine, less indicated for lumbar spine, but we are still doing it if indicated. And now coming to fixation, this is a traditional fixation surgery. This is my patient. This was 10 years ago I did this surgery. I still show that because you see this is the black area is the decompression area, and this is the fixation, the rods and screws going into the spine. But to do that, I have to do a big cut in the back. I have to spare a lot of muscle dissection, a lot of, you can see how bloody is the field, how much inflammation I would cause, and this muscles will heal eventually, but will cause a lot of fibrosis and scarring. So to put screws above and below the normal level, I have to disrupt the anatomy. But nowadays we are doing this with minimally invasive fixation. So we are putting screws through simple cuts in the back only. We do not dissect muscles. We put a dilator, we separate the muscle fiber, we reach the bone, we put screws, and we come out. No blood loss, no dissection, nothing, and then in a small port we put a cage in. So this is the difference between a traditional spine surgery and a minimally invasive spine surgery. But obvious in this patients, the recovery is much better here. Patients are able to walk next day after the surgery. Patient can go home after 3 days of surgery. Here this patient will not get out of the bed for 3-4 days because the pain he will or she will go through after this surgery. And this is the crux. This is an old patient, again old image. This is the summary of a minimally invasive spine. Simple cuts in this skin, K-wire, Jamshidi needles, through this K-wire goes, through dilator goes. Surgeon's hand-eye coordination is important. This is an X-ray image. This is how we end up. So my eyes are only on the monitor. I'm not seeing the patient. This is the nutshell, no blood loss. And this is the patient post-op, immediate post-op. This is patient after a few weeks, and this patient is able to walk after 2 days of surgery. He is discharged. Next day, sometimes in the evening, we make this patient walk. But the problem with minimally invasive spine surgery is because we have to do a lot of x-rays, AP, lateral, AP, lateral. So single spine, minimally invasive spine surgery fixation I'm talking about, you might end up doing 16 to 17 x-rays, maybe 20 episodes sometimes. That is radiation exposure to me, to my patient, to my nurses, to everybody in the operation theatre. For that, we are now using spinal neuronavigation and 3D CM. So we don't do more than 2-3 x-rays now. Navigation systems in neurosurgery, just like your GPS in your phone, the Google Maps in your phone, it exactly tells us where to go, where not to go, and we are able to put screws, we are able to remove brain tumors. I'm going to come to that as well. With very precise location, very precise placement of the tumor. So here you see the purpose of this photo at the very end is my eyes are on the computer monitor, on the image guide console. The image will guide where my screws are going. This is the implant which has been placed with minimally invasive technique. The purpose of showing this image is I'm seeing actually the navigation console. My X-ray console is behind me, so I'm not watching the previous आपने जो image देखी होगी, I was watching my X-rays when I was doing spine surgery. Here I'm watching the console of a navigation system. This surgery we are able to place precise screws with navigation system. This is a navigation system. This is one of our assistants. So we are placing the screws under navigation system. This is an X-ray which is done before surgery. So this is a patient who came to us from Sudan. Somebody operated on the back here, cervicodorsal junction, and left it unfixed. The patient neck started to fall down. He started developing quadriparesis. We do fixation under neuronavigation. The advantage of neuronavigation is if this screw in the lower thoracic region is 2 millimeters inside the canal, patient will end up with paralysis and will wake up with a complete paralysis, which is a big complication for any spine surgeon to cause. But with the navigation, I am able to place with a millimeter accuracy, 1 millimeter accuracy, I am able to place the scan. It's just like BrahMos for us. So it puts in the screws wherever we want to, and this patient, this is nutshell. बट अगर मैं बोलूँ कि सारी सर्जरी में MIS से कर देता हूँ या कोई सर्जन स्टार्ट्स टू से कि नहीं हर सर्जरी में एंडोस्कोप डाल के कर दूंगा एंड एवरीथिंग इज एंड वी आर लाइंग. Not all cases are suitable for minimally invasive spine surgery. For example, this young girl, a 27-year-old HR executive, came to us with a very severe port spine. So her cervicothoracic junction was completely destroyed by port spine. You see this big abscess here. She developed quadriparesis. She was not able to walk. She came on a wheelchair, urinary problems. She is a known case of pulmonary tuberculosis. Then that tuberculosis went to spine. In such a big case, I have to go from the front, I have to open the chest, I have to do a complete decompression, remove a lot of spine, and then put implants in. It is not possible through minimally invasive surgery. And then we have to go from the back, so it is called as a 360-degree fusion. And this is the nutshell. So after this kind of surgery, we will say what is the life of this patient, a 27-year-old girl who is bedridden or a wheelchair-bound girl who has undergone a big surgery and a caught spine. She won't be able to walk in. She won't be able to do anything for the rest of her life. But this is the surgery. This was what we were able to achieve. From the front, we had to do a thoracotomy with help of our thoracic colleagues. We mobilized a bit of arch, and then we were able to put a big implant here, remove all the bones. This is what we achieved. This is this patient 10 days after surgery. Wow. This is this patient's 3 months joining back at a joining, and this is on her request. I am showing you this photo that she said, "Sir, please बताइएगा कब तक जाके कि this is possible." So she's gone back to her. Now she's getting married very soon. Now coming to brain, I'll just quickly go through it. The neuronavigation, as I said, we are using it regularly. This is a tumor in the brain of a patient. This is post-op image. There is complete removal of the tumor. Navigation actually guides us. We are able to pinpointly locate the tumor in the brain. We do not do nowadays collateral damage in the brain. We exactly pinpoint that. Navigation shows us that this is the tumor here, a small cut in the brain, a small craniotomy. We remove the tumor and we come out. We do not do any collateral damage to the brain. So the patient, the complications are less, the scar is less, patient is discharged very early. And nowadays, see, this is again a case with a patient who is a 12-year-old boy who came with a tumor in the thalamus, in the basal ganglia region here, sitting here. and started developing weakness. MRI showed this tumor here. Previously, we used to refer these patients to radiotherapy directly because operating here is a death sentence for the patient. If we reach that deep, we are going to cause either a major hemorrhage or a bleed or a complete paralysis for the rest of the life. But without knowing what kind of tumor it is cancerous, non-cancerous, high grade, low grade, we used to send this patient directly to radiotherapy and see whatever happens got decided. But nowadays with navigation, we are able to put a needle exactly in the center of the tumor, remove a part of the tumor and send it for examination. We still do not operate most of the cases. In some cases we do daring surgeries, but this is the tumor, this is the biopsy procedure, this is my navigation system, this is my trajectory. I am able to place needle directly into the tumor tissue, take sample out and come out of it. It is minimally invasive surgery, only small hole in the skull. We are able to nowadays put endoscope and remove some part of the tumor also. But what happens, इसमें सबसे बड़ी problem brain surgeries में जो होती है, किसी भी patient में होती है, the patient, this surgery is usually done under anesthesia. If we are doing some damage to the brain tissue, few millimeters here or there, patient might wake up with a complete paralysis, or patient might wake up with a aphasia, is not able to speak. We don't know what's going on inside the brain. Navigation can show us where we are, but it doesn't show us the function of the brain. The function of the brain can only be showed by the patient. That is where we do awake craniotomy. It means we keep the patient awake when we are doing the surgery. आप लोगों ने पढ़ा होगा कहीं कोई पेशेंट ब्रेन सर्जरी के टाइम पर वायलिन बजा रहा है, कोई हनुमान चालीसा पढ़ रहा है during brain surgery. That's what I'm talking about. So this is a 23-year-old patient who came from Yemen to us with a low-grade tumor sitting right on the area which controls motor cortex, which controls your hands and legs. This is a DTI image. The blue fibers which you see here is your corticospinal tracts, and this tumor is sitting just anterior to it. So if I am a few millimeters posterior, I will damage this patient, and this patient was completely intact when he came to us. He came with seizures only. And if the patient wakes up with a paralysis, and a young chap, if I have given him paralysis for the rest of his life, it is a big complication for me to cause and the patient to be here for the rest of his life. So in this patient, we keep this patient awake. We ask him to write the name, his name. We make him practice, and you will see in the video, this patient is reciting Quran also when he's doing surgery. But during this time, when we actually open the brain and the patient is awake, we stimulate the brain. As soon as I reach the motor cortex, and जैसे ही मैं motor cortex को stimulate करता हूँ, patient का हाथ से पेन गिरने लग जाता है. His handwriting changes, so we know it is a motor cortex area, and we mark it as not to go area with special stickers, and we do not go there. And we remove the tumor piece by piece with time to time stimulating. So, audio नहीं है इसमें? Okay. So this patient is actually reciting Quran while we are stimulating the brain and operating. Now you are seeing he's writing his name, and suddenly his pain will stop, and the pain will start there. So this is the time where we are stimulating the brain, and suddenly the pain stops falling. So we know that we are in the motor cortex, and we save this area. This is this patient 3 days after surgery, completely intact. Another patient, she is a cancer survivor. In fact, she was a cancer survivor, breast cancer patient with a routine PET scan, just a routine PET scan after 1 or 2 years of surgery, breast cancer treatment, and they found this metastatic tumor growing right in the left frontal region in the Broca's area. Broca's area is the motor speech area. So I'm talking because my Broca's area is working. You talk because your Broca's area or motor area is working. This is bang on the motor Broca's area, motor speech area. And luckily she was intact. This tumor, if it would have gone increased in cost, it would have caused him aphasia for the rest of her life. If I had operated this patient on a normal anesthesia, and a few millimeters here and there, if I would have done any damage, the patient would have woken up with a very difficult speech problem for the rest of his life. So we can cause aphasia, which is very, very troublesome. For this patient, we did an awake craniotomy. This case was picked up by Times of India also. We were very lucky that it was published in Times of India. This patient, during the entire surgery, was chanting Gayatri Mantra. So before surgery, we told her what to do. There had a lot of psychological confusion, physical, and a lot of other counseling which goes, and we have to explain to the patient that you will be awake during brain surgery. You will not be in any pain. This is a special type of anesthesia which we give. This is a navigation image. This patient, our anesthetist will ask him to recite. I don't know whether you can hear it or not, but this is this patient immediately after surgery in OT. Wow. So she's still able to chant Gayatri Mantra. We were able to remove this tumor. This is a tumor before surgery. It is gone after surgery. This is this patient 5 days after surgery and was discharged without any deficits.
Great, sir.
Thank you, sir. So this is all technology. This is all training. This is what we do. Again, but there are certain cases where we are not able to do that. Patient को heart problem है, renal problems है. Patient is a known epileptic patient, can throw a seizure during the surgery, so we cannot keep them awake. For example, this patient with a glial sarcoma sitting on the motor cortex. In those cases where awake craniotomy is not possible, we do cortical mapping. In this cortical mapping, we do operate on the brain, we do stimulate the brain, but it's just like your ECG for your heart. We do brain monitoring on the system, and this brain monitoring actually tells us where we are. Then we map the motor cortex. When we have any finger movement, we say to the finger area, there's a tongue movement, we say tongue movement, and we mark the motor cortex. We separate it and we remove the tumor. So this is we are doing. This is the pre-op scan. This is the post-op scan with intraoperative cortical mapping. Pituitary adenomas are very notorious tumors. Almost monthly we are operating 3-4 cases nowadays of pituitary adenoma. It is done through the nose. Endoscopically we go through nose. Pituitary is the cellular region is a very, very compact region. Then you have carotid arteries and cavernous sinuses on the side. You have optic nerve on the top, and then you have sphenoid sinus. So this sphenoid sinus gives us the area where we put endoscope. Nowadays we are putting endoscope under navigation guidance. एंडोस्कोप का सबसे बड़ा प्रॉब्लम ये है, या लैप्रोस्कोप का भी प्रॉब्लम ये है कि इट इज अ रिजिड मेटल ट्यूब, तो वो आपको केवल आगे की चीज़ दिखाएगी. Whatever is on the sides of the tube you are not able to see. So if you are in brain, if you are few millimeters or centimeters here and there, if you are damaging a cavernous sinus or a carotid artery, you won't know. You will see red blood coming on the front, but in the side what is happening you don't know. That is where the navigation system helps us. So navigation actually tells us on the MRI where in the vicinity of carotid artery I am. And in the front I can see the tumor. So I do not venture on the lateral side, I can see the optic nerve but I cannot see the carotid arteries. So this is a 60-year-old lady with a severe headache, vision loss, lethargy, and there was this big tumor sitting here. And this patient is a bitemporal hemianopia and she underwent a navigation guided endoscopic decompression or excision of the tumor. So this is a navigation setup. This is my endoscopic view. As I said, जो मुझे आगे है वो दिख रहा है. My endoscope is showing what is in front of me, but what is on the sides, this MRI is showing me on the sides. So I can see my carotid arteries, I can see where I am. Further to add that, we use intraoperative Doppler. So it's a small probe, just like your Doppler. It gives us the exact sound where we are. So once we reach there, once we put our endoscope there, we put this Doppler probe. And I don't know if you can see that. If you can hear the audio.
Yeah.
So this is the pulsation of a carotid artery. So this is our Doppler, small machine, imported from Japan Vizio Corporation. And I'll just play it again. I'll put it on carotid. So I know this is the area, no-go area. I should not venture there, and I do not go there. And I will not cause any damage. So this is the pre-op image, this is the post-op image. The entire tumor is removed and without any causing any damage to the patient. Now two more sites I will not go anymore. Deep brain stimulation surgery is one of surgeries which is very close to my heart function. I am a functional neurosurgeon as well. For advanced Parkinson's disease, patients who have Parkinson's 5 years plus who are levodopa responsive, patients who have OCDs, severe OCDs, patients who have dystonias, we are able to put deep brain stimulation systems. It's just like a pacemaker for your heart, we put pacemaker for the brain. It's just like a battery under the clavicle with the wires going into the specific area of the brain. In advanced Parkinson's, we put in the thalamic nucleus, subthalamic nucleus of the brain. These are the patients who have tremors, who have rigidity, who cannot walk, who are fascinating at and fall. And this problem becomes so severe that after a certain time, the medicines, especially levodopa, stops working. And you have on and off effect. On effect is when medicine is working, and off effect is when medicine doesn't work. So there is an on effect, you are good. Off effect, you start getting your tremors. This keeps on increasing, your dose increases, persistent dose increases, and you start getting hallucinations. So you are getting side effects of the treatment, your disease is progressing, and eventually it is life-threatening. In those cases, we are able to do deep brain stimulation. It is done through hysterotaxy. This is a case, a patient from Sudan who came with a severe Parkinson's, advanced Parkinson's, 8 years post diagnosis. He had dislocated his shoulder once because of the severe tremors he had. This is the crux of a deep brain stimulation surgery. This is our neurologist, Dr. Khushbu. The patient is, the wires or the electrodes are placed with a stereotactic frame into the subthalamic nucleus from where this Parkinson disease comes. We stimulate that area and we nullify the signals coming from the tremor. So this is the basic hypothesis where how DBS works. So, and she is checking for rigidity and bradykinesia. They will also ask the patient to tap and see whether tremors are gone. This is while we are stimulating the brain. So this is the recording. We do recording of the brain, exactly where we are, and this is the area where we are. This is our target area where the green and the red lights we have seen. This is the stereotactic frame, and this is the wires. We are stimulating the brain. Again, another patient. This is again our doctor checking for the rigidity, whether the stone has improved or not. So this is this patient before, and this is this patient after surgery. So this patient was completely dependent on the caregivers to eat food, to take bath, or to dress himself. He was completely dependent on somebody. But now, after this surgery, he is independent. He is a warlord in Sudan. He participated in the civil war after surgery. He has 3 wives. Now he's got 5 after the surgery. Yeah. So advantages. So this is again one of our patients just before surgery, unable to walk. This is this patient after maybe around 3-4 weeks of surgery. So another patient, severe Parkinson's patient, very difficult life, very difficult life. And this is this patient post-surgery, stimulation surgery. He is able to write his name. Wow.
How long this stimulation stays? Lifelong?
Yes, most of the time. The rechargeable battery can last up to 20 to 25 years, and then you replace the battery. So it goes. This is another patient before and after surgery. And one advantage, the limitation of this technology, most चीज़ पे आने वाला था, the recent advances के हम बात कर रहे हैं, the limitation of this technology is patient has to come to me again and again for reprogramming, at least for 3 months. Current up, down, there are current frequency, lot of parameters which we do. Current frequency and patients sometimes lost in follow-up, they give up. They give up because it बहुत बार आना पड़ रहा है, especially international patients. The device which we are putting are now Wi-Fi compatible devices. So again, the recent advances are helping us. So these devices we can, with a good Wi-Fi connection anywhere in the world, patient is sitting anywhere in the world and I am sitting here, I can actually program the device while sitting in my office, and this patient is in Sudan and we are reprogramming this patient. This patient is sitting in his home and we are just checking the device is working fine to increase the current or decrease the current. So this is where technology has gone so far.
सर ये तो हैक भी
हो सकता है सर, इसकी सैटेलाइट लिंक स्पेशली खुलती है, पर ये हैक आपको किसी बड़े आदमी को लगाओगे तो उसको डर रहेगा, नॉर्मल इंसान को क्या डर रहेगा। ये अगेन DBS का 13-year-old boy with primary dystonia. It is very difficult to control, but we can make their life better. And this is in post-op, better still. But here, this fellow was completely dependent on his mother. Now mother is slightly released. We are able to do that. Again, the target is GPI. One last case I am going to show, because this is a pediatric neurosurgery last case. The 10-year-old boy with at least 12 to 15 seizures in a day. And this life has become hell. He was dropped from the school, completely dependent on mother for feeding, drinking. This is this patient during video EEG. You can see a seizure coming out during the video EEG. There has to be sound, but you will be able to appreciate the seizure. There. And this is this patient at home, immediately after seizure. He cannot even go to bathroom on his own because you never know whenever he will have a seizure and he fall down. the seizure is happening here. This was a tumor on excision which was out, and this is this patient walking after the surgery. He was on several anti-epileptic medicines. Currently he is on 2. His seizure frequency has come down to 1 in a week from 15 in a day. We are very hopeful that in coming future it will come down and he should be able to go back to school. So thank you. Thank you so much. I'm just a small part standing there. This is the entire team. This is all possible because of the team we are having. This is a support team and our neurologists and senior doctors which are possible. Thank you so much.
Dr. Nath, thank you for a wonderful session on some very interesting cases that you showed. I just wanted to ask you one thing, sir. You don't take any guarantee that if you operate, the person will get married 5 times, no? You are not taking any guarantee.
Marketing के लिए
मतलब ऐसी कोई गारंटी तो नहीं है ना?
सर मैं आपको इतने पेशेंट भेजूंगा, अगर गारंटी लेती हो आप?
अगर नहीं हुई तो आप करवाओगे सर ऐसा? ठीक है, कुछ लोग पूछ रहे हैं, पीछे बैठ के पूछ रहे थे कि
सर यहाँ पे गारंटी लोगे तो फंस जाओगे। यहाँ ट्रिपल तलाक के बाद बहुत सारे चक्कर चल रहे हैं, एक से ज़्यादा नहीं चाहिए।
Dr. Padar sir, to set the context for the meeting, and then we go ahead with the Q&A.
I think everyone will agree that this was a very nice presentation covering almost all the aspects of neurosurgery, brain surgery, spine surgery, endoscopic surgery. So I will ask only 2 questions because there are many learned people in the audience. They will ask many questions. So something about awake craniotomy. What sort of anesthesia you are giving? So only local or something else you are doing?
I'll just answer for that. So awake craniotomy, there are 2 types of. Okay. So awake craniotomy, basically there are. I will not go into too much details. There are 2-3 types of anesthesia. One is awake. So you keep the patient awake throughout. So we use dexamethasone, Dexam, and some short propofol. We do not do any intubation to these patients. So we keep the patient awake throughout the surgery. See, brain is a pain. Brain doesn't have pain receptors. So brain is painless. The dura, your pericranium, the dura matter, it is painful. So once you are able to anesthetize that part, and then you are able to reach the brain, it is pretty painless surgery. The challenge is anesthesia. The challenge is keeping the patient awake, and the challenge is seizures. Where epilepsy it can happen. So you keep the patient awake, or you keep the patient awake. So you anesthetize the patient first, you put an LMA, laryngeal airway mask, and then you do the craniotomy, you reach the brain and you make the patient awake during the surgery. And then you do the surgery, you see what the functions are, and then you awake, and again you do the sleep cycle. You again put the patient to sleep and you close the surgery. So this is awake, and awake, sleep. These are 2 main products. So we normally do awake now. Previously we used to do sleep, but now we are doing awake.
So in sleep, you put on laryngeal mask,
LMA.
then you remove an LMA, and then patient is awake, then you do whatever you want to know from the patient,
Yes.
again you put LMA.
Sometimes we give deep sedation only, and because closure is not a challenge. The only problem is opening is challenge.
So second question, in cervical spine area, disc replacement, you are also doing here also by minimal invasive method?
No, sir, disc replacement itself, we do minimally invasive. Most of nowadays we respect tissue a lot, and I'm talking about newer generation surgeons. So it is done through a small cut here in the neck. We only reach
Front of the neck.
Front of the neck, always front of the neck. It is under the skin, so we normally do not put stitches nowadays. It is under subcuticular, and we put nowadays the skin glue, so there is no scar. So patient wakes up without any scar.
Okay. Thank you. Dr. Chauhan.
Dr. Sanjeev Naik.
Sir,
Sir, I just want to know lesion which is present in the both ventricle. It is lobulated. 55-year-old female presents with what is going to be your course of action on that?
So first of all, we have to see the morphology of the tumor and whether there is a hydrocephalus or not. So if there is there is hydrocephalus, and if I am able to remove the tumor completely, then I will do a CSF diversion during the surgery, putting an EVD or a drain to reduce the internal pressure and remove the tumor. If the flow of the CSF after the tumor removal becomes okay, then patient will not require any shunt surgery. However, if in spite of removing the tumor because of the scarring in the brain, the aqueduct or the CSF pathways are closed, then this patient might require a second surgery, which is a VP shunt surgery, after 1 or 2 weeks of surgery. Tumor surgery.
When you see this patient, would you do any kind of a biopsy or you go ahead straight for surgery?
You are talking a fourth ventricle tumor.
Yeah.
Fourth ventricle tumor will not do a biopsy. We normally go and take it out. Doing a biopsy in fourth ventricle, you have to open it any which way. So it is better to take it out. And see, whenever we are going to remove the tumor, we are going to send it for biopsy any which ways. But the fourth ventricular tumor, if it bleeds, then it is a catastrophe in a biopsy.
This patient, within a week, as you realize that there's a diffuse intraventricular bleed.
Sorry, again?
Diffuse intraventricular bleed.
After the biopsy?
After the surgery within a week.
Within a week?
Yeah.
Within a week, then we have to find out why. Because most of the surgical bleeds happen immediately or next day. Within a week, if there is a bleed, then either that one of the hemostatic vessel wherever you have done hemostasis is opened up, or there is some sort of other bleeder which has been left unattended, which has opened up.
This is something which I would like to know. If I have to take care of this patient when it's discharged, is there something special that I really have to know?
So it depends on the clinical status of the patient. If there is already a brain hemorrhage happened, and especially in the fourth ventricular area, then your brain stem is at risk. So if the patient's vital structures, your reticular activating system, the patient is conscious or not. What are the parameters?
Yes, now eating. Yes.
Now eating.
Yeah, eating. The patient is going to be discharged. I'm just asking, it's a very personal, I'm supposed to take care of that patient.
Understand.
So anything you would advise me to take really?
I would like to go for an angiography of this patient, CT angiography or an MR angiography, just to make sure why he bled or she bled after 1 week of surgery, which is very unusual. So that, and then probably an MRI, repeat MRI after 6 weeks, contrast MRI. And depending on the biopsy, whether radiation is required or not, that is one of the things.
Dr. Bhalla, sir.
Sir, chances of seizures after intracranial operations?
Chances of seizures in patients who are already epileptic because of any tumor. So, not depending on the location. Patients who have cortical tumors, patients who have tumors in the temporal region, they tend to seize a lot. So patients who already have epilepsy because of the tumor, they tend to seize a lot. And patients, just because of the brain surgery, the chances are around 2 to 4%. Some series say less than 2%, some series say 4%. But it depends, I would say largely depends, in my experience, depends on the location of the tumor and how much scarring you have caused. If it is a large tumor, you have a lot of cortical scarring. As a result of surgery, you can have a scar epilepsy. There are delayed epilepsy episodes also. Patients come after many years with seizure, and you do a PET scan or a video EEG, and you find out that the surgery जहाँ आपने करी हुई है वहाँ से epilepsy अब आ रही है after so many years.
But you must be giving prophylactic anti-epileptic drugs in all the patients.
We give prophylactic
Yes.
anti-epileptic. I have it for 6 months.
I have to give a prophylactic epileptic.
Thank you.
Dr. Anurag, sir, Dr. Akash Kesri.
Sir,
Yes, sir. Slightly different question I have. A very nice presentation, sir.
thank you.
But recently I was watching an interview of the patient who had undergone the first Neuralink implant. Neuralink implant, right?
Yeah.
I wanted to know from your perspective, do you think that that is something which is viable like more broadly, or is that a very specific application, or do you think that is more, or is this not real science, or what are your thoughts on these type of implants which are giving the patients that capability?
And the very onset right now, I think this looks very promising, especially for patients who have cortical blindness, patients who have occipital degeneration, patients who have your camera, I mean your eyes and everything is okay, your optic pathways are open, and you are able to see things. I think before this Neuralink has happened, somebody has already put it in China in persons, and they are already doing some semi-autonomous. They are able to control machines with the gestures. It looks pretty promising and scary at the same time. We'll see how it happens. But as of now, I would be more, as a surgeon, neurosurgeon, I would be more interested in knowing how it is helpful in spinal surgeries, in spinal injuries, and specifically patients who have cord transection, patients who are paraplegic or spastic paralysis. Are we able to communicate the normal spine above to normal spine below in transections? So those areas.
One more thing, sir. Have there been any advancements made from a neurosurgical perspective in the management of glioblastoma? I know this is a very sort of difficult thing to approach.
Glioblastoma multiforme?
Yes,
so there are a lot of developments happening. There are newer drugs coming. The latest development which is happening, the developments are happening in different fields. So for example, in surgical field, I can tell you we are using special dyes where we give the patient, it's called as ALA. So it's a very expensive dye, patient brings it, and we have special filters under a microscope. So whenever we are removing the tumor, this tumor becomes violet, purple, fluorescent violet. So the normal brain doesn't look like that. So you are able to differentiate the tumor tissues and you are able to remove that, so the extent of resection increases. And the extent of resection is also directly associated with longevity. So that is one thing. Second, we are using intraoperative chemotherapy. We are using carmestine wafers. So if we are able to remove more than 80 to 85% of the tumor and patient tumor is not in the ventricle, then we are able to put wafers of carmestine, like an intraoperative, intracavitary chemotherapy, which helps to control the disease. So these are the few things which we are doing it for years now.
But usually prognosis is, I'm here, Dr. Saxena. Usually the prognosis is very bad in
जी भैया मैं कम वार्ड में सर मतलब कितना भी प्रोग्रेस हो गया है 9 months to a year
maximum one year like.
Yeah, if it is a peripheral tumor and we are able to remove it out completely, I have had patients who have been surviving for last 5 years also, which is again not rule, it is exceptions to the rule, but there are good patients with 12 years, 24 months also. Not 12 years, 12 months.
In general, prognosis.
In general, I would say it's very gloomy. Very gloomy. Not around a year maximum.
Dr. Jitendra Saxena.
Good evening, sir. My question is, you mentioned in all your slides that PET scan was done, but you never mentioned whether it was PET CT or PET MRI.
PET CT.
PET CT. So you think PET CT is as good as PET MRI?
No, I mean PET MRI has its own limitations and indications. PET CT, I would right now, as of now, the availability of PET CT is
PET MRI is hardly available in Delhi, only very limited places.
But if it is available, would you
if it is available in epilepsy, yes, it is better. In epilepsy surgeries, I would prefer to go for a PET MRI. But normally, I would go for a SPECT if possible. PET scan actually shows me the metabolism. So in epilepsy surgery, what is important is the area from where the seizure is coming becomes doesn't glow out. So there is hypometabolism in those areas. This is a tumor will be avidly enhancing, will show more metabolism. So in epilepsy surgery, we see hypometabolism, which can be, a PET CT scan is as good as PET MRI for me, because we are using navigation-based MRI anyways for the tumor. So going for a expensive investigation in an epilepsy surgery doesn't make a sense, because we have PET scan, normal PET CT would give me the same information.
Sir, because most of the time we are left confused, because at the end of the PET CT report, they mentioned that PET CT is not the modality for diagnosing. The report itself says.
Yes.
So that it's not the modality if you're looking for it.
So the best modality is, I mean, if you're talking about tumors per se, the best modality is biopsy itself. You remove this and you send it for examination. Even the PET MRI will not be confirmatory to you.
PET CT not for diagnosis of any tumor anywhere. It is only for staging. You have to diagnose by other means. PET CT is only when you diagnose, then you do for staging in anywhere in the body.
See, the concept of PET is an FDG PET, if I have to generalize it, is basically metabolism. You see the metabolism, where it is hypo or hyper. If it is hyper, it can be infection, it can be tumor, it can be a lot of other things also. It's not just indicative of tumor. So in itself, it is not a diagnostic investigation. It is more of an adjuvant investigation to help you out and to follow up cancer patients when in metastatic diseases. If you are suspecting a metastasis, for example, today only, we saw a patient, she has an L1 lesion. L1 body is almost completely collapsed. And PET scan it is enhancing, but there is no other area of avid enhancement on the PET scan. So we are suspecting it can be a myeloma or plasmacytoma. So we have to work on that. So we have to take a biopsy. But the only way of knowing that is if I go there and take the tissue out and send it for examination, which we are planning to do. So That is a confirmatory test. PET scan, I would use it as more of a diagnostic tool rather than a 100% diagnostic tool. I would still not say it helps as a radiological test.
Staging and in follow-up.
Exactly. It tells you whether it is an M1 disease or not, M0 or M1.
So my second question is, you mentioned that for the deep tumors, you are doing that navigation for pinpointing the tumor.
That's right.
So does the proton radiation, does it in any case help it, or is it some kind of augmentation, or maybe pre-op proton radiotherapy decreases the size of tumor, deep tumor, you are able to take it out easily, or post-op proton radiotherapy?
See, proton radiotherapy is a type of radiotherapy and navigation is different. So navigation is necessary for us to use during the surgery. But proton as such has a very good indications in chordomas and other tumors. And the collateral damage is very less, it is very precise. But if you are giving a radiotherapy to a tumor and then you are operating, then there is a chance that your biopsy will be negative. Or sometimes you are dealing with a radionecrosis rather than the tumor itself, because sometimes after 6 months or so, that radionecrosis on MRI looks exactly like a tumor. So then you have to do a perfusion scan. So patient who comes to us, there are a lot of patients who comes to us fast post radiotherapy. Then we go for a MR perfusion scan and MRS along with MRI. So if there is a hyperperfusion in that area, it means that it's tumor. If it is a hypoperfusion, it means because the proton or any radiotherapy is worked and it has caused necrosis. Then if it is a hypoperfusion, then we do not do biopsy. It means it is radionecrosis.
So proton radiotherapy would be good for certain type of tumors exclusively?
Exclusively, yes. Chordomas, I would say, areas where you have a lot of complications, the brainstem tumor, brainstem area where you have a lot of cranial nerves and any collateral damage will cause a devastating complication to the patients. So again, proton is very expensive. That is available in, I think, Chennai.
Only there are two centers having proton radiation. One is Apollo Chennai and one is Tata Memorial Bombay.
Tata Memorial Bombay is
recently purchased it. Only it was in Apollo Chennai. Now TMH.
Even in UK when I was working.
Even AIMS is trying to purchase it. It's 50, nearly 60 crore. 60 crore is cost. 60 crore.
Thank you.
And I met one scientist from DRDO in Delhi. He is in Basantpur area. You will be surprised. It was a RSS meet, but there was a guest lecture from that side. He is almost in the final stage of this research. He is much advanced than proton radiation. Much advanced. And he is also first Indian made MRI. He almost many companies are tying up with him. So I will call him sometimes in our great center.
Right, Dr. Poddar. We have Dr. Pawan Chaudhary, brother in arms for Dr. Anurag Saxena, an eminent neurosurgeon, previously at Balaji Action, now at Gangaram. He plans to undertake a trial and he will demonstrate for sure how many marriages more you can go ahead after surgery on spine, and he will demonstrate better results than Dr. Anurag Saxena. But he has a different question now.
Congratulations, sir. Very few surgeons are covering all the stairs of the neurosurgery that you have shown us. And just one or two questions. First of all, the functional neurosurgery that you showed, the role of DBS. So there is an upcoming sphere, the MR guided ultrasonography. So have you tried that, or are you performing few cases? Have you done?
No. You see, this one is in Coimbatore and another one is in Ganga. There are two machines in India. MR guided focus ultrasound ablation.
Yes, it shows a very promising results, especially the tremors, dystonias.
It does. See, there are a lot of other centers. I will be going to go there for one of the sessions also. The challenge, right now it is expensive. Say 16 lakhs or 18 lakhs for one side, so into two. That is one thing. Second is, it is an ablative procedure right now. I'm not comparing it with DBS. I'm just giving you my take on the technology. It is an ablative procedure, so it's ablated. So it is a one-time go. There is no coming back. In DBS, if it is not working, you switch off the DBS. If the patient is having a side effect, you switch off the DBS. But in MR first, once you've done it, you've done it. So then again, after that, doing a DBS will become a challenge. I mean, in an ablative lesion already, if there is a lesion, putting a DBS and a redo DBS as we call it, then it becomes a challenge. So there are advantages and disadvantages both. Right now, it is an upcoming thing. In India, it is available in 2 centers. As the cost will come down, obviously it is a less invasive, it is a non-invasive procedure. And if the results are comparable, then probably we have to compare both technologies. But the advantage of DBS is it is reversible.
One more question, sir, regarding the neuro navigation point. So, as neuro navigation requires a lot of pre-operative planning, and even a small 1 mm error while the initial pre-operative stage could result in a long term in the intraoperative stage, it can lead to blunders. So, have there been chances that when you have overruled the decision of the, how often has it been there, you overruled the decision of the neuro navigation machine and you chose a different trajectory?
It happens, see, the technology it fails. Sometimes it fails. Even what happens is there is a lot of brain shift when you are operating intraventricular tumors. You are operating tumors where you have opened the skull and then you suddenly find that the brain sinks in. So there is a shift in the brain. So you lose that accuracy. In those cases, we sometimes abandon neuro navigation. And so we plan it beforehand. We plan the shift also. I have normally planned the shift also, that this much shift might happen. But in tumors which are intraventricular, I don't use navigation anymore. Once you have hit the ventricle, you have lost the navigation because suddenly the brain shrinks and you lose that distance parameters.
Sir, you have inspired our neurosurgeon Dr. Pawan Chaudhary. For the first time in last 1 year, he asked questions. For the first time. Sir, it is always better to have a government perspective, and who better than Dr. Badwa, who is practically owning Satyagram Hospital, minus the deed.
Good evening, sir. Sir, indications for cervical disc replacement in cervical spine, and why it is more than the lumbar spine?
So lumbar spine actually, first of all,
most of the PIDs occur in lumbar spine.
Lumbar spine. So lumbar spine artificial disc, I used to put a lot in UK. So you have to go retroperitoneally, and then there are a lot of complications, especially premature ejaculation and retrograde ejaculation, other complications are there. Because the degree of motion which you get is not that significant. In cervical spine, we normally go for patients who are young, who do not have any osteophytes, who do not have any degenerative disease, who do not have any facetal problems. In those cases where end plates are parallel, we use normally. There are now, this disc has been, for so long this disc has been there, so there are certain now very good discs, we are putting Bagheeras and other things which do not fuse. But previous disc also, if the patient selection is not right, it will act as a cage and it will fuse eventually. So if patient selection is very important, especially in patients who are operating multiple levels, and I am going to fuse the spine, then the degree of motion is not there, then in 1 or 2 levels you can put an artificial disc. But if I am putting 3-4 artificial discs, I have to be very sure. And then there is a degree of translation during a flexion extension. If there is too much, then I will not put an artificial disc. I would like to fuse it.
Indications for this?
Indication, as I said, no osteophytosis, young patient, and parallel end plates. Only disc is the problem. Facet joints are not the problem.
This desiccation is the indication.
Desiccation is the indication.
And are you putting baclofen?
Yes, regularly.
Yes.
Great questions, Ranjan. Sir, before I give it to my masters, I wanted to ask you a question, sir.
Yes, sir.
One of the contentious places where you operate is the brainstem area. Suppose you have a cystic lesion in the brainstem area. How do you approach it? Because there is so much less space and you have to be exactly precise. Before you commit yourself, as Dr. Pawan said, even 1 millimeter can be an issue. Kindly enlighten us about the brainstem.
So brainstem as such, diffuse gliomas, spontaneous gliomas, we do not operate nowadays. The standard protocol all over the world is directly shift the patient to radiotherapy because it is a death sentence to the patient if it happens. In patients who have an exophatic tumor, where the tumor is coming into the fourth ventricle, we still like to go and take it out. In patients who have cystic lesions or cavernomas who have bled, or cyst we have bled, there are certain areas of the safe entry zones in the brainstem where we go through and we try to take it out in the navigation guidance and other things. So it depends on the location. If the tumor is anteriorly placed and I cannot go posterior because I have to go through the brainstem, then I would try to avoid it. Patients where tumors that are placed near the surgical corridor, I will still likely go and take it out. But in diffuse tumors, we normally do not do anything because life expectancy is not more than few months. If you do surgery, you do not do surgery.
Dr. Saxena, I also wanted to ask you, and a lot of people were asking, do you also do CV junction, craniovertebral anomaly?
Yes,
and
C1, C2.
And what is the prognosis?
Prognosis is good. Depends on what stage patient is. Patient has already come up with a cord damage, then the prognosis is guarded obviously. Any spine surgery, I will always say to my patients and to my doctors as well, is the spine surgery is usually preventive in nature. It is largely prophylactic. So spine surgery is when you do, the benefit in the pain and any functional recovery is the bonus. So in C1, C2, it is more important because as a patient who comes in an intact patient, in a walking patient, there are more than 95, 97% chance that he will go back walking. Patient who has already come on a wheelchair, we do the surgery, but the cord damage or the myelomalacia still remains. So the patient feels sometimes unknowingly betrayed that I have done surgery and I am not getting better. So you have to explain to the patient that the staging of the surgery and the condition of the patient actually dictates the outcome.
In certain CV junction anomalies, especially lateral to axial dislocations in young people, do you also do bone grafting along with the titanium?
We normally, it depends, if in the patients, certain patients we do a spacer placement, just like a cage placement in C1 and C2, and then we put the screw and fixation. So we normally do not do bone grafting anymore. We have implants to do that.
Because they usually say that all the implants, even if you put in titanium, just by the sheer force of dynamics of the body, they all give away in time to come. So it's better to give a bone graft, and maybe many old timers do that even still.
That's the old school. My boss used to put a graft, bone graft. To still take it out bone graft, and even cervical disease in C1, C2 put an spacer, instead put an iliac bone graft. So we do that, but nowadays the implants are so good that, and the fusion rates are very high, is another thing. So I have rarely seen any implant failure in C1, C2 in my opinion.
Right. To my masters, Dr. Tulsi and Dr. Kalvasan.
Thank you, Dr. Chauhan. So, great talk, Dr.
Thank you, sir.
So, can we say which has been the longest brain surgery till today? Anybody? Any of my friends, including Dr. Anurag Saxena?
No, sir. I can
Dr.
tell.
Conjoint twin decapitation 36 hours. Conjoint twin decapitation.
Wonderful. So, how many hours and how many days?
36 hours.
No. Take a guess again.
48.
No. You're close. Go ahead.
56.
103 hours over 4 days.
I didn't know that.
So even I didn't know till I read. So great talk, sir. Talk us about the high grade gliomas, grade 4. Glioblastomas have a dismal prognosis. Patients living for just 8 to 16 months. And now today, even after the TMZ, which is the latest chemo drug today, which may or may not cross the blood-brain barrier, we have dendritic cell therapy. Talk us about dendritic cell therapy, the latest innovations today in neuro-oncology. Talk us about that, sir.
So neuro-oncology, as a surgeon, as far as I am concerned, we are limited to intracavitary chemotherapies and temozolomide as the doctors, and that we seem to medical oncology.
Let me say.
Is their field.
Let me say.
Maybe our young neurosurgeon might be able to give some shed light on something.
No, we need an oncosurgeon here.
A medical oncologist to be precise.
Or an oncologist.
Medical
Anybody?
oncologist.
Nobody. Okay. Let Dr. Kalra would like to say about that. Would you like to say? No. Okay. Okay. So, Dr. Rak, please take a seat there.
I'm happy sitting here.
Okay, great. So we know 60% of the patients who are on dendritic cell therapy would probably prolong their lives beyond 18 months. And 1/3 of the patients would probably have a permanent cure. This is a landmark trial completing phase 2 trials. This is absolutely, I mean, what can I say? A dismal prognosis where you live hardly for 8 to 16 months. And here we have, my last question would be, before Dr. Chauhan takes away the mic from me, regarding aneurysms.
Right.
So, surgical clipping versus coiling, endovascular coiling, and another modality, probably, diverting the flow.
Flow diverters.
Yeah, so flow divert. So talking about this, and majority of the aneurysms would probably not burst, but some, how do you distinguish whether aneurysm will burst or not, and what is the modality of choice we have here? So amongst the three, would you say, is it the endovascular, or is it the surgical clipping, or is it the divert flow? Talk us about that.
So result-wise, if you compare the surgical morbidity or mortality as compared to an endovascular treatment, nowadays they're almost similar in good hands. But in certain cases, like an IC aneurysm or a posterior circulation aneurysm, we'll like to go for an endovascular replacement. That's all. In a patient, sorry, sir?
I said wonderful.
Right, and in cases where there are IC aneurysms which are difficult to clip, and we are expecting that we might leave some remnant behind when we'll clip and it might grow back. Flow diverters have come up recently as a very, very good alternative. So eventually what happens is it diverts the flow. It doesn't actually cut off the flow, it diverts the flow. So aneurysm still takes few months, 1 or 3 months to disappear. Sometimes you have to be very, very sure. But the downside of any putting flow diverter is that the patient has to be on at least 2 antiplatelets. One of them is ticagrelor, as you call it, which is a very, very strong and antiplatelet, and along with aspirin. So for 6 months we normally keep these patients on. In patients who have a hemorrhage with a clot inside the brain, or like an MCA bifurcation aneurysm, where you are already going to do surgery, life-saving decompressive surgery, I would like to clip the patient and do the decompression surgery. But in a patient who is intact, surgical clipping in a patient who is already going to operate any which way because of a clot or a MCA bifurcation, which is just
irrespective whether it's burst or not.
No, sir. If there is a hemorrhage, it means it is already burst.
So SAH.
Yes, as an SAH patient who is going to require surgery any which ways for removal of the clot, I would like to go for
Dr. Raj, tell us, how would you probably diagnose if the aneurysm is going to burst or not?
Aneurysm is going to burst or not, so there is no diagnostic test up till now which can say the patient is
aneurysm would not burst. Unless and until.
I would say it is right to say that nowadays we don't know. There are criteria. There are a lot of studies which we used to study in our MCS days. But large now size is not a criteria.
So we are talking about aneurysms which would burst or would not burst. Is there some criteria?
Sir,
small aneurysms would not burst.
No, it's other way around sometimes. The bigger aneurysms will not burst, smaller ones will burst sometimes.
Sir, my one comment and one question, sir.
Right.
Have you ever heard about the Dhichi? The Dhichi was Maharishi who donated his spine. His spine was made of
all bones. He donated all his bones. All bones.
spine.
All bones.
सर उसको मेरुदंड बनाना था, वो स्पाइन से ही बनता था, बाकी बोन से क्या लेना देना, स्कल से क्या लेना, हाथ से क्या लेना. It was, yeah, I am telling you, I know about Shiv Puran. It was Merudand Indra lost in Rishi Pulat's yagya and all that. Anyway, sir, so he donated his spine because it was destined to be Vajra and the best of more than steel. So मैं ये कह रहा हूँ कि क्या आने वाले टाइम में कभी स्पाइन डोनेशन भी पाइपलाइन में है क्या?
Transplant की बात करें सर?
Yes.
Spine transplant?
Yes. Sir, I am saying because brain, heart, lung, liver, kidney, they are all vitals. At least the spine can be semi-vital, if you can say. can it be transplanted?
Not in the near future. जो मुझे लगता है सर, spine is actually a structure. It's not an organ in itself.
Yes.
So it has a spinal cord, it has bones, it has nerves and everything. So unless we are replacing the entire thing, and then the biomechanics have to go to it, then the blood supply is different. Whenever you are transplanting an organ, it has a separate blood supply and a separate venous drainage.
I understand, sir.
In spine, you have separate blood supply for bone, you have separate blood supply for nerves, you have separate blood supply for your spinal cord itself.
Sir,
and they are very microcells.
जब हम TBT की बात करते हैं, टोटल बॉडी ट्रांसप्लांट की बात करते हैं, तो वहाँ भी ऐसा ही है कुछ.
So yeah, when we say total body transplant, is actually in speaking is brain transplant.
Sir, now that I just want to give one question was from my side, that epilepsy, lesionectomy. So in case of a lesion like a tumor, and in case of NCC, neurocystic psychosis, how does it differ in management?
So lesionectomy, there has to be a definite lesion and it has to be surgically available for resection. Like I showed, it's a simplest form of epilepsy surgery which I have shown. And then are the other epilepsy disconnections and other things which we normally do in pediatric. I have a series of that, but I have not shown it right now. So lesionectomy is the child which I have shown you. There is a lesion which is responsible for the epilepsy, proven on video EEG and a PET scan or a SPECT scan. Then we go and remove the surgery, we remove the tumor or the lesion. If it is NCC and it is peripheral, then we also go and remove it.
Thank you, sir.
Unless normal tiny NCCs, we do not give to anything.
Thank you, Dr. Anurag, for a wonderful session and some wonderful cases you have shown. Thank you, sir. We have become wiser. I would give it to my moderator to summarize this CME for us.
I think it was one of the best CME on neurosurgery because you covered almost all the aspects, including brain and spine. I mean both brain and spine and endoscopic surgery and for Parkinson, for epilepsy, everything you covered. So I think, thank you. You all are now wiser after your lecture. Thank you very much, Dr. Saxena.
It was my pleasure. Thank you.